talking about with like the 43 gene panel? Is that right? Or we're doing 50?
Okay, so it's not typically the one we were talking about, but it's kind of similar idea. So can you exactly tell us what was the question they asked to you?
So they were asking us if we had something similar or whatever. They're like, you know, this is breakthrough technology that they're providing us with, and do you guys have anything in the works? And I was like, yeah, you know, like our NGS thing, we're working on it. New York validation is tough, et cetera, et cetera. But I wasn't sure if like that 50 gene thing that we were talking about, whether it was conference call or training, is that similar to like what they have, like what they call liquid biopsy, or is liquid biopsy something different?
So basically, liquid biopsy is something different, but it's very, very much related to the next generation sequencing. So here's the idea. So remember when we said there are two, actually we can go find this in the presentation. So okay, so I'm gonna start with this, Nuran. We have Lauren. She may have the same question. I'm gonna start with this. When we go to the presentation, I'm gonna use one of the slides to explain this idea. So let's just put this on the side for now. Lauren, you have a question? Go ahead.
No, it was the same question. I just said it's a good question to have answered.
Okay. So is any of your accounts asking you about the liquid biopsies this week?
I did have a doctor, this has been a couple months ago, but he doesn't do any bone marrows. So he said, yes, when we start doing liquid biopsies, then he'd like to start sending to us.
So I'm actually trying to track what are the information the other reps are providing for the offices they are using, because I just have the feeling that Genoptics are now like having a campaign that they are going after all their offices and accounts and hot leads and everything, and telling them about the next generation sequencing. So I'm just trying to know if there's any other lab doing this or not, because
I know the doctor I'm speaking about. I know that he uses Genoptics.
So he uses Genoptics. Interesting. And he said he doesn't do any bone marrows or peripheral bloods in his office.
He does peripheral bloods, and so that's kind of what he said, like when we can start doing the testing on the blood instead of the bone marrows, that he'd be interested. So that's why I'm like, kind of the same question. Does that mean if we're doing the same types of testing on the blood, is that considered a liquid biopsy? Is that kind of what that terminology means?
No. So here's the question. Is this doctor a hematologist oncologist or just medical oncologist?
Hematologist oncologist.
So he's a hematologist oncologist, and so most commonly the tests he orders on blood, we should be able to do them. It's just like bone marrows.
Okay.
We should be able to do flow and cytogenetics and molecular and everything on the peripheral blood as well. So why I don't think that Genoptics is doing liquid biopsy so far. Of course, they are trying to develop the technology. It's very, very complicated and very, very costing, very, very expensive, and costs us a lot of money to develop. So I think they are working on it, but they don't have it yet. So if he's saying that he uses Genoptics because they offer this kind of technology, this means he is talking about the hematology stuff.
Okay, so all I really know, to be honest with you, is that they've used Genoptics in the past. They tried us one time last year, sent us a peripheral blood sample. Can't remember which test that they ordered, but I'm just looking into my notes right now. And he specifically asked about when we can perform the EGFR and KRAS testing on liquid.
Okay, I just want to jump in really quick. Sorry not to cut anyone off. The chick I spoke with today said the same thing. She said that the liquid biopsy that they were doing, they said that they were doing it on KRAS or with KRAS. Sorry.
Okay. So we can actually work on we can actually do the KRAS on peripheral blood. We don't have a problem with that. Let me check. So you guys got the email from Nihal that has the updated requisition form, right? Or test menu. She was adding some stuff to the test menu, right?
I haven't gotten anything.
I didn't see anything. Yeah.
No, nothing.
It's not soon. Maybe like a couple of weeks ago.
No, I don't think so.
No, I didn't get anything either.
Nothing.
Okay, sometimes I'm just copied in some emails, but in a wrong way because I have the same name as Kareem al-Wakil, his work, so that's why maybe I'm getting this email.
Dude, we have like 6 Mostafas. I think you guys are all cousins.
I'm sorry?
We have like 6 Mostafas in the company. I think you guys are all cousins.
Yeah, I'm not sure why. There are 3 people who has the same initials as me, like KE. So most of the time I'm receiving emails from them, and they are receiving emails from me, like emails that I should be copied in, and the same, So just a second.
Hey, not to jump off topic, I just typed like 2 questions I have so I don't forget, but whenever you're done or whatever, if you could just explain what's KRAS and liquid biopsy when you're done with your presentation.
Okay,
So I
sure.
can get an education, please. Thank you all.
Okay, you are welcome. Okay. Remember it was okay, so well, I'm just trying. So what I'm trying to do is I'm trying to get the updated the updated test menu or the. So I know for sure now we're doing KRAS. I just wanted to share this email with you guys or the.
Kareem, can I add something while you're checking?
Okay, sure, go ahead.
So guys, the liquid biopsy it's called circulating cancer cells, CTC. The idea behind it is basically it's if anybody of us has a solid tumor, God forbid, like for example prostate cancer, breast cancer, colon cancer, lung cancer. The idea of it, you know something called metastasis, right? Which is the primary tumor will try to invade other tissues. So the idea behind the test is basically rather than the doctor go and take a biopsy from the lung or the colon or the prostate, which is an invasive procedure that needs anesthesia and all this kind of stuff, he would just take a blood sample and look for the circulating cancer cells that this primary tumor is trying to send to other tissues. So it's like trying to track the middleman. It's like trying to track the delivery person, basically. The problem behind it is it's a high ticky test because rather than the pathologist is able to detect a large volume of cancer cells using the regular tumor markers, using the biopsy that we have been used to use for 30 years. Now you have to detect the cancer using only like very few number of cells. And they do this not only on blood, they do it on urine sometimes as well. Like for prostate cancer, they can detect it from urine sample. What I know for sure is that we don't do circulating cancer cells right now. I have been asked these questions like you guys by many accounts. Has repeatedly said that we don't do them right now. I really wish that we get to use them because they are very useful in so many cases. Doctors don't do bone marrows or don't withdraw blood. We can still get the business if we do these kinds of tests, but I guess it needs a lot of validations that we didn't go through.
I'm sorry, Aziz, you said that this is the explanation you gave is for KRAS or for liquid biopsy?
No, it's detecting liquid biopsy. It's detecting the cancer cells itself. So if the doctor wants to see if the patient has a breast cancer, rather than going and taking a biopsy from the breast, he would just take a blood sample and look for the breast cancer cells in the blood.
Nice. And this is something we haven't really developed or anything, right?
No.
Oh man.
Well, Dr. Nasser, when I got this question back in June, I actually called Dr. Nasser, and he said it was in the process of being validated, but didn't have a date when it would be.
Okay. So
Anybody else heard of that?
Normally, I think Ahmed tells us that we should call Dr. Nasser when we're in this situation, but I'm too scared to do that. So
yeah, sure. Well, so basically, thank you, Aziz, for the explanation. So basically, this is the idea. So so the idea is, remember when I was saying, guys, that there are that when we were like the oncology started, any disease in the world was kind of surgery. It can be treated by surgery or drugs, right? There are only two ways to treat any, you know, in the older days. It was just two ways of treating or management of a disease. It's either surgery or drugs. And when we started, you know, knowing more and more about cancer, it was either treated by surgery or drugs. And this was because those tumors are, most of the time, they are solid tumors. Sometimes they are liquid tumors. So now basically all the tumors in your body are solid tumors, which means they have to be in a solid organ, like the liver, the heart, the bone, the intestine. There has to be some flesh in the organ so that it can turn into cancer, because basically cancer is overgrowth of a tissue that compresses and pressurizes the adjacent tissues. So this is basically the idea. Almost all the tumors in our body are in solid organs. Only the hematologic tumors are liquid tumors. So basically, for a pathologist to diagnose that this is cancer, he has to get a specimen from the solid tumor, and this specimen is fresh tissue. Okay, so that now he can look under the microscope and see the cells that are transforming into malignant cells, and they are disrupting the normal histological appearance of the tissue. So basically, for a pathologist to say this is cancer, he has to get a fresh tissue specimen from a solid tumor. The only case this doesn't happen is in the liquid tumors, because you can't get a fresh tissue. That's why we get either a blood sample, a peripheral blood, or a bone marrow sample, so that there is some tissue we can look at, a bone marrow biopsy, that is, even though the tumor is not in the bone marrow, but this is the factory that makes the blood cells, so we can look at the factory and expect what's in the peripheral blood. So this is basically the idea. So now the new technology is we are able, so usually if you have, God forbid, if somebody has a liver tumor, so some of the cells of the tumor actually just go in the blood, go with the bloodstream. They are very, 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 very few. Before, we didn't have any way that we can detect those small cells and then sequence them, you know, look for the mutant genes in them to be able to identify and say this is a hepatocarcinoma, a tumor of the liver. We weren't able to do this because this is very, very, very complicated technology. Those are very few cells in the blood. You know, it's very, very, think about it. What are the odds that the very few number of the cells go in the 1 centimeter or 2 centimeters of blood you draw from the patient's arm? So we were not able to look at those cells in the blood to say there is a hepatocarcinoma, okay? But now, with the next generation sequencing techniques, we are able to sequence a very few cells. We can hybridize them and look at their DNA, and then we are able to see the mutant genes and say there is a hepatocarcinoma. Those cells are from mutant liver tissue. And since this is a very, very, very new technology, it's just developed over the past 4 years, it's still under the research. So since this is a very, very, very new technology, not a lot of labs are able to, excuse me for a second. So not all of the labs actually developed this technique or able to diagnose this. But the ones that have done this, they now are bragging, we can diagnose a breast cancer, we can diagnose a hepatocarcinoma, we can diagnose a GI cancer, we can diagnose a gynecology cancer from the blood, because we are able to sequence the very few cells that are in the blood. So this is basically the liquid biopsy, and it has nothing to do with the liquid tumor, because liquid tumor we can diagnose it from the blood anyway, because the problem is in the blood. But for the solid tumors, the problem is in the liver, but the mutant cells can go in the blood, and we can find them in the blood. And why are we doing this hassle for ourselves? Why are we trying to do this? Because basically, if we can diagnose this tumor from the blood, so this is a biopsy-free diagnosis. Instead of, just imagine, for the normal procedures now, for a pathologist to diagnose there is a problem in the breast, he has to get fresh tissue, right? And how are we able to get the fresh tissue from the tumor? The patient has to go to the operating room and go under general anesthesia, and the surgeon, do surgery to her breast and get the tumor out, and then we send the tumor to the pathologist to examine it. But now we can say this is a breast cancer biopsy free. We don't have to get the biopsy, and this is going to change everything. So now a medical oncologist sitting in his office can see a breast cancer patient and just ask his medical assistant to get a blood specimen, send it to the pathologist, and know the diagnosis, with saving himself the hassle of sending the patient to a hospital or surgery center to get the biopsy out. So this is basically the liquid biopsy thing. Do we do this thing in CyberDyne? No, we don't do this in CyberDyne. Why? Because it's very complicated and we don't have the technology to do this yet. But some of the tumors, they share the mutant genes. So because we only developed the panel for the blood tumors, remember when I was talking last time about the next generation sequencing, we said we have the panel for the myeloid tumors, right? So that we only developed this panel for the myeloid tumors, the 43 genes, but some of the genes are mutual between the different panels. Like for those genes may be involved in breast tumors as well, maybe involved in hepatocarcinoma as well. So basically you can test for them. One of them is the KRAS, the NRAS, the EGFR. So for some of the doctors who want to diagnose a breast cancer and just they are looking for the EGFR, we can do the EGFR for them. Not because we are able to do a full breast cancer panel, but just because this test is mutual between the breast cancer panel and the MDS panel, the myeloid panel.
Okay. So, will you just repeat that one more time? So the way you put it were that there's some genes that can
be involved.
What? Be involved.
So basically, let's say there is a patient that has breast carcinoma. This breast carcinoma, remember, it's all DNA fault. So there has to be a mutant gene, right? Now we don't know which gene. We are trying to look for which gene has made this problem to this patient. Then we have to have a breast carcinoma panel, which tests for all the genes that might be involved. It's like when you have your car checked. the problem may be in the motor. It may be in the electricity circuit. It may be in the tires. We don't know. We have to check the entire car. So now we have to check for all genes that might be involved in the breast carcinoma. Okay, is that clear? Then it's the same for the myeloid tumor. Myeloid means bone marrow problem. A myeloid like leukemia or lymphoma. So for this patient to have leukemia, it's all DNA fault. There has to be a mutant gene. Now we know that there are almost like 70 genes involved, might be involved in the problem. We have a panel that tests for all those genes. Some genes might be involved in breast carcinoma, and those exact genes might be involved in MDS and myeloid carcinoma. One of them is KRAS, one of them is EGFR. So it's a mutual between the breast carcinoma panel and the myeloid panel. Maybe a doctor has a patient of breast carcinoma and he just wants to test for the EGFR. He doesn't want to do a full comprehensive panel for breast carcinoma. He just wanted to test the EGFR. Can we do this EGFR for him? Yeah, sure we can. Can we do this KRAS for him? Yeah, sure we can. Not because we are able to do a comprehensive breast cancer panel, but because we are able to do a comprehensive myeloid panel that share the same genes with the breast carcinoma panel. Have I made this any more clear? Any clearer?
Yes.
Great, really?
Dude, you're the freaking man.
I'm sorry?
I said you're the man.
Thank you very much. I really appreciate that. So now if you get the question, do you guys do KRAS? Yes, we do. Do you guys do EGFR? Yes, we do. And here's one. Just a second. Okay. Here's the email everybody has. You guys see my screen?
Yes.
Okay, so those are the genes that we have by next generation sequencing. Those are the myeloid panel, and here you can find somewhere here, I just can't find it. KRAS and NRAS and JAK2 and BRAF. Those are the tests most commonly you're going to be asked for, and the EGFR it's somewhere here.
So what's going to be the best way to use this information? Is it going to be best to share with all the doctors? I know you mentioned that mainly pathologists are the ones that are most curious. So how would you recommend sharing this with?
I'm sorry. What's the pathologists are the most curious part?
Well, you were kind of saying that it's more the pathologist, right, that would be interested in this specific information. Isn't that what we touched on last time?
No.
Oh, okay. Maybe
a hematologist oncologist might be interested in this. So a medical oncologist who is treating a breast cancer patient, he is suspecting that the problem might have happened because of the EGFR gene or the KRAS gene, and he just wants, because remember when we said the targeted therapy depends on which gene is mutant. So he now wants to give the patient the targeted therapy for her. He wants to know if she has the EGFR mutated or not, which means she's going to respond to this drug or not. So he's just testing for the EGFR. He's a medical oncologist and he wants the EGFR to be done. Now the normal standard procedure is he's going to send this patient to the hospital. So she's going to do mastectomy, and they're going to get the fresh tissue, the specimen from the fresh tissue, send it to the lab, whatever lab it is. The pathologist is going to look at it and say, yeah, this patient has breast cancer, and then they're gonna do the molecular test for her and say, yeah, she is EGFR positive patient. This means this is the drug best for her. He's a medical oncologist, but now the medical oncologist is not the person to get the biopsy, because he's just medical oncologist, not surgical oncologist. He's not able to perform the surgery on the patient, so he sends him to the hospital. But with the new liquid biopsy technique, he is just gonna send it to his medical assistant, send the patient to his medical assistant. She's gonna get a blood specimen from him, send it to the lab. The lab is gonna do the molecular test and say, yeah, she is EGFR positive patient. Is that clear?
Yes, I guess I didn't really phrase my question right. How would you recommend using this document? Like, do we print it out and go ahead and start taking it to our facilities, or are we waiting for new marketing material or sales tactics as to how to introduce this to the doctors?
Well, actually, I don't have an answer for this question, but it's open for all of us to think about it and say our suggestions. It should be in the new marketing material. I don't know. Some of the doctors are going to be asking about this. So now, you know the answers. You can go ahead and print the menu and keep it with you. Like whenever he asks you a question, you hand it to him. But the optimum thing from my point of view, this is not like me discussing it with Ahmed or Dr. Nasser. It's just my personal opinion. Is I think we should go after all of our doctors and show them that adopting this new technology is going to make the diagnosis even better for them. More precise diagnosis, more informative diagnosis. This is personally my own idea, and I think Genoptics is doing this all the time. So now they are sending the reps all over their accounts, or all over the offices, and they are educating the doctors and the medical assistants about the next generation sequencing, and showing them how this is gonna improve the quality for the diagnosis and be more informative, and it's gonna affect the decisions the doctor is gonna take to cure his patient. They are very knowledgeable about this. They have a lot of studies with them. They are going all over the place educating their doctors and their medical assistants. Because, yeah, I know most of the doctors might not be interested in this. They don't even know. Or they just hear about it and they don't know how this is going to affect them taking actions. And actually, I and Vanessa came across one of the accounts that asked us specific questions about this, because just the rep of Genoptics was just there and was just telling them about educating them about this just before we went in the office. So this is my personal opinion. I think we should all know about the next generation sequencing and go educate our accounts and encourage them to order more and more of next generation sequencing tests. And tell them the benefits they are going to make, specific case scenarios where this is going to affect their decisions and their actions, and this is going to encourage them more and more to send to us, because they know we are like state-of-the-art technology. We have the state-of-the-art technology, and this is going to encourage them to order more of next generation sequencing, which is more profitable for us. So what do you think, Lauren? What do you think should be the best way to use this information?
Yeah, I mean, I agree with you, especially since our competition is out there. I think we need to, let all of our doctors know. I guess I just don't want to word it wrong. It's like, okay, we have 43 genes, and here's the list, and you know what I mean. Like just the best way, maybe to sell it, as far as like you were saying, we have more genes than some of the other labs, so that would be a benefit to using us. But just more information, but yeah, I'm excited to start sharing the information with the doctors.
Yeah, I actually we have to start developing like a pitch for this, to know what are we gonna tell our doctors or accounts. I and Vanessa last week we had this first time lunch with a doctor, and the first question he asked us, like we were just saying, we are a hematopathology lab doing full service bone morphology and cytogenetics and flow cytometry. We were just at the headline of our pitch, and he asked, do you guys do next generation sequencing? The first question, he just, I mean, this is kind of new practice. The doctor just started this practice, and this is like the first question he asked. Do you guys do next generation sequencing? What's your panel? He wasn't interested when I told him like we do a 43 gene panel. He wasn't interested. Maybe he doesn't even know what this panel consists of. He's not interested. He just want to make sure that you guys have this new technology. That's it. You are equal to the other labs. I'm not sure if GenBath is sending their reps, all over, just marketing this technology, because it has nothing to do with the the hematologist oncologist is not. Lauren is out. Maybe she dropped the connection. So I mean, there is no. It's not very common that the hematologist oncologist himself is gonna order this panel or ask for a specific test. It's not common. Remember when we were talking last time and we said what are the indications for this panel? Most commonly, like 95% of the times, the pathologist in our lab, Dr. Nasser or Dr. Rahman or Dr. Tao, he is the one who's gonna order this panel. Okay, so he's gonna be the one ordering this panel, just because he can't find definite answers from the other tests. The hematologist oncologist who orders full consult is not even gonna know that what are the tests the pathologist has ordered. He just wants the results. As long as he has the results, he doesn't care. So in 95% of the times, he's not the one who's gonna order this panel. The only 5% of the times that he's gonna order this panel, that he knows exactly what does his patient have. Like he has CML, the patient has CML, and he knows that the patient is not responding to this and this and this of the chemotherapy, and he wants to add targeted therapy, and he wants to test for this exact gene or this exact panel, which is, it's not kind of common situation. So most commonly you're not gonna come across specific questions like this from a hematologist oncologist. The ones that ask you about the KRAS and the EGFR, those are asking for this for liquid biopsy, which is for solid tumors, for like breast cancer or hepatocarcinoma or GI carcinoma, because they have like this is more and more important in their diagnosis. Like the BCR-ABL, you're gonna have a lot of questions about BCR-ABL. This is important for hematology actions. But the exact NGS panel, the 43 genes, I don't think the doctors know most of them, the hematologist oncologist. But the thing is, Genoptics has a perfect marketing team. They are going after the doctors and telling them, we adopted this new technology, this is gonna affect your actions in this way. The doctor didn't ask them about it. They are going there and offering their new technology. And that's why if you are coming after them and the doctor wants to compare, he would ask you, do you do this? He wants to know which one of us is better. Did you get the idea, guys?
Yes, thank you.
Welcome. I think we lost Lauren. So this is basically the idea. I'm not sure actually how to market this. What should be the sales pitch for this? I don't know. What should be the marketing material for this? I don't know. But it has to have something says what are the benefits for the doctor, right? Yes,
Yeah. I guess maybe this is something we can talk to with Ahmed about. Maybe like we can all kind of put together a sales pitch or something.
I think we should all develop this, or at least like maybe Ahmed develops like a prototype, and all of us develop it. I don't know, but I think
we could do it at our group meeting or something.
I feel like if we had the sales retreat by now, we could all sit around together and discuss this like awesome salespeople we are. while enjoying drinks poolside. I just think we'll all work better. If you ask me, I mean.
Right. So where do you suggest to have the sales retreat? Because this is really important as well.
I think we should let Vanessa decide because she knows.
So does that mean Florida, I guess?
Florida? No, not Florida anymore. Now I live in Florida.
Come to California.
Mexico, Mexico.
Mexico, right?
Really?
Oh yeah.
Mexico?
What do you mean really? It's the best place. A resort there. Wow, it's beautiful.
Okay, all right, Zoe. I'm sorry, man. I feel like I offended you.
Yes. Or you want Michigan? You want Michigan instead of Mexico? Let's start with M.
No, come to California, guys. I think that's the best place.
Yeah.
I know Ahmed loves Michigan, so maybe Michigan's not a bad idea.
I know, right? Did he already tell you?
He did. He was complaining.
He told me that it's like the worst place.
Guys, I'm going to California. Aziz, I'm with you.
Okay,
What
we
about
should
Nebraska,
join
guys?
Mexico.
Got one vote here.
How do you feel about Nebraska?
I have no idea about Nebraska. Just no idea.
No, thank you.
How about Guatemala or Honduras?
Yeah, here are more interesting questions. Or the Bahamas.
Oh, yeah, that sounds good.
Let's go to Hawaii.
Hawaii. Yalla.
This
Yalla.
is going to be a one-way ticket. You guys realize this. We're not coming back to our territories ever.
Yeah, we can go with Ahmed, you know. Take him there and okay, we can work from Hawaii, all of us.
Doc, I'm in Hawaii. Who cares about NGS?
It looks like we're all dreaming about the sales retreat.
Yeah, seriously, man. I know I'm burned out. I don't know about you guys. Like, I need this thing ASAP.
Yeah, somehow we have to let management know about the idea of sales retreat.
Yeah,
They
sure.
keep, delaying it, keep postponing.
No, we're due for it. I feel like it'll be much better. I think we can all it'll be a meeting of the mind.
Yeah.
Right?
Nuran, you know what? I feel like I missed the whole summer. I didn't take any, vacation time, and now I feel really bad. More than that, I got sick.
Yeah, no, I hear you. I'm the same way. I'm like done.
And I really need, at least like several days of nothing.
Yeah.
Just, thinking about something, talking.
Yeah, my summer was bad as well.
Ahmed an email said that we kind of decided that we need it and that's it.
What? I'm sorry, I didn't hear that.
We're just gonna send him an email telling him that we decide we voted and we
Yeah.
go for it.
We should time our leave when he's on his honeymoon, and then that's it.
Yeah. Yeah. Right.
Look how everybody suddenly woke up. Oh my God.
I feel like I just started some trouble. My name was not here at all. Don't mention me, please.
Yeah. Right.
Yeah, Ryan, what are you trying to say there? Why do we time it when he's not available?
We're just gonna say it's Omar's idea. What do you think?
Oh,
I love that idea. It was Omar, and he says he was annoyed today, and he wants a sales retreat now.
Perfect.
thanks, Naran.
Okay. Okay, so now we have made a sales pitch for the sales retreat. We all wanna. Katrina had like a busy summer. Nuran feels he's burnt out. Vanessa's moving, and Omar is accepting that he wants a sales retreat right now. And Aziz wants us to go to California. So like we now came up with a sales pitch. We can just arrange it together, and say it to Ahmed and give the deal.
Let's build a syndicate, guys.
That's what? I'm sorry?
Let's build a syndicate. It's
Yep,
like
sure.
a workers' union.
Mm-hmm. Yeah, right.
We should call for our rights.
And then we all get fired.
Yeah, Naran's gonna start it too.
Yeah, or we will get fired, or the lab will go bankrupt. Two things can happen.
Okay, sure. Okay, so now we have to go ahead with our hematology part of the training. So yeah, it should be fine. Today is a really small part, so don't worry about that. Let's go to the showcase app and click on the cancer and hematology presentation. I'm sorry for nobody now is is excited anymore about the training. Everybody's thinking about going to Aruba or the Honduras.
Yeah, dude, I'm going back to taking a nap again.
I actually start packing.
Great. So I'm gonna be so fast. So this is a small part, so that you don't have to worry about this. And I can give you some homework to do, like whenever you have you are in the right mood. So let's go on. I have now most of the guys here with me on the presentation. So we are talking about the types of blood cells. So remember, this whole episode should be talking about the basic biology of hematology and oncology. We have talked about the oncology part. Remember when we were talking about the genes and what's involved and what's not involved in the problem of developing cancer, and what should be the lines of treatment for the cancer. And now we're gonna have like a basic background about the biology, the blood, the hematology part. So basically, the types of blood cells are three main types: the RPCs, the platelets, and the WBCs. RPCs are red blood corpuscles or corpuscles, which basically the red blood cells, the platelets, and the white blood cells. So the red blood cells main function is to carry oxygen to the tissues and carry the carbon dioxide from the tissues. So they are like the most numerous cells in the blood in the bloodstream. Their normal lifespan is like 120 days. So they like you change your entire set of RBCs every like 4 months, and yeah, basically they are the most they are not involved in many diseases that we can deal with, but they are involved in the anemia, they are involved in the hematoglobulinopathies. And this is, by the way, like, remember when we say the difference between us and the GenPath, that they have a normal routine blood testing panels or chemistry panels that we don't have. Basically, this is dealing with the RPCs and the platelets. So this is basically the RPCs. They are the transporters. They transport the oxygen and the carbon dioxide back to the different organs of the tissue. The platelets are the healers. They are involved in the process of stopping the bleeding. They are, kind of the first rescue squad that goes to the site of injury and start, building a network of fibrin that blocks the sealing part and, keep us from losing our blood. They are like the fewest number of cells in the bloodstream. Some of the textbook don't even consider them cells. And the WBCs, this is like the most important part. So the WBCs are the cells that defend our body against the foreign or the strange materials that come in, and against the viruses and bacteria and all those kind of organisms that attack our bodies. And they defend us against the cancerous cells as well, the mutant cells. They attack them and kill them. Basically, of the WBCs, we have two major types: granulocytes and agranulocytes. And granules are like the small vesicles of chemical material inside the cytoplasm of the cells. So when we stain them, remember we were not able to see them. The first thing we knew about them when we stained them. So some types of the cells had granules and they stain, and some of them doesn't have granules. That's the meaning of granulocytes, which means granular cells, and agranulocytes, which means the agranular cells. And this This again is divided. The granular cells are divided into three main types of cells: the eosinophils and basophils and neutrophils. This is depending upon the color of the cell, how what's its color under the microscope. So eosinophil stains red with H&E stain, which is the basic stain we use to examine the blood, and basophils stains blue. So eosin means red in Latin. So basically, this is the cells that stain red, and basophils the cells that stain blue. And the neutrophils, they are neutral, they don't stain red or blue. Who wants to say something? We have Lori. Welcome, Lori. She just made it. Good for you, Lori. So we were talking about the types of blood cells, and we were talking about the white blood cells. They are the defenders of the body against the foreign organisms and foreign materials that attack the body, or the mutant cells. Okay. So there are two main types of them: granulocytes and agranulocytes. And the granulocytes are either red, blue, or neutral. They don't have a specific color in the stain. And the lymphocytes, they are basically two types: B cells and T cells. B stands for bone marrow, which means the lymphocytes that are developed in the bone marrow, or they were first discovered in some gland in the birds. I'm not sure. I just don't remember the name of the gland. It starts with the B. That's why they have the B the B cell standing for them, and the T lymphocytes because they are developed in thymus gland. That's just next to our hearts. A small gland that's rudimentary in the adults. Like it's up there and big, and working when we are children or adolescents. When we reach puberty, they just get atrophied. So those T lymphocytes are developed in the thymus gland. That's why they have the letter T. So we have basically two different types of lymphocytes: B lymphocytes and T lymphocytes. And this is tells us about two different types of lymphomas: B lymphomas and T lymphomas. Remember when Dr. Koder was sending some emails about the B cell arrangement and the T cell arrangement, he was referring to the lymphocytes and the monocytes, which is type of the white blood cells that's mostly involved in the macrophages, in the phagocytosis process, which means eating the other organisms. It's like a very big cell that basically it eats and digests the foreign organisms. This is kind of a very basic background about the types of blood cells. What are them and what are their jobs? The RBCs, the platelets, and the WBCs. And there is the video this is actually a video from Khan Academy about the hematopoiesis. I want to go, so I was planning to show this video while we are on the presentation, because it just gives us a very basic background about the hematopoiesis and how these cells are developed. And now, since everybody is excited about the retreat and everybody's sleeping now, nobody's interested in hematopoiesis anymore, we can take this for as kind of homework. I'm gonna be sending the link for this exact video in the email, so everybody watches it. It's like 12 minutes talking about the hematopoiesis, and we can discuss it in the next episode. Now we're gonna go ahead and talk about the last thing about hematology is the scope of hematologic disorders, which means what are the hematology disorders that the hematologist oncologist is gonna see. Remember when we were talking about the hematologists, and they can see benign hematologic disorders versus malignant hematologic disorders. Like an average attendant in the hematology oncology department in a hospital, actually he's gonna see more benign hematology patients than malignant hematology patients. So most of the patients he says he examines per day are when we're talking about his hematology part are benign hematology patients. They have anemia, they have problem with coagulation or whatever. This is basically like his biggest volume. Some of them are going to be malignant, but most of his patients are going to be benign. So basically, the scope of hematologic disorders is problems that can happen with the RPCs, problems that can happen in the platelets and coagulation process, and problems that can happen with the WBCs. So the problem that can happen with the RPCs are either loss or decrease in the number of the RPCs, and this is called anemia. Actually, an in Latin means no, emia in Latin means blood. So anemia means no blood, which basically refers to the decreased number of the RPCs in the blood. And this is not a one disease. This is a huge group of diseases, and it can either be a disease itself, or it can be it can be a sign for another diseases. And this is a very, very huge kind of branch of medicine, working with anemias and trying to figure out what is the cause for the anemia, and trying to resolve this anemia. This is a huge part of the hematology work. And the hemoglobinopathies, which means hemoglobin, which is the molecule inside the RPCs that's responsible for attaching to oxygen and the carbon dioxide. And pathy means disease in Latin. So hemoglobinopathy means the problems or the diseases of the hemoglobin that's inside the RPCs. And a problem that can happen in the chemical composition of the hemoglobin molecule can change the shape of the RPC and yield it to be less functional, and make problems for the patients. So hemoglobinopathies are like the thalassemias or the spherocytosis, if you are familiar with those kind of diseases. So those are again the problems that can happen in the RPCs. And then the problems that can happen in the platelets, either the hemophilia, which is it's a rare disease. Yeah, it's a rare disease, but it's still an important one that can affect the patients, especially the younger patients. Hemophilia, which means the patient is more prone to bleed blood from minor trauma than usual average human body would do. So hemo means blood, philia means like in Latin, which means the patient likes the blood. He's actually bleeding a lot from minor trauma. And then the idiopathic thrombocytopenic purpura, which is purpura is another group of diseases that can affect the body. They are manifested by small red spots or rash on the skin. So this is another huge group of the hematologic diseases, idiopathic thrombocytopenic purpura or ITP, and the hemophilia. And the third part of the scope for hematologic disorders is the WBCs, the white blood cells, which basically are involved, which basically the blood tumors, the leukemia, lymphoma, and multiple myeloma. The different scope of blood malignancies can be involved in the WBCs, can either decrease the number of the WBCs, which called leukopenia. Leuco means white in Latin, penia means little, so leukopenia means little blood cells, the decreased number of the white blood cells in the blood, or leukocytosis, which means increase in the number of the white blood, increase in the number of white blood cells in the blood, which is the most common presentation of a patient with a bone marrow problem or blood malignancy. So you would always hear this sentence from a hematologist oncologist. He says, if I have a patient with leukocytosis, I want to run the tests for him. So basically, for a doctor to know that the patient has leukocytosis, he has to do a CBC. That's why we always ask for the CBC results to be shipped with the peripheral blood specimen, so that we can know what's there. So a leukocytosis is like the most common presentation for a patient with blood malignancy, which means increased number of the white blood cells. So this is like a very basic background about hematology. You should by now have the time to read the PDF file that's talking about the hematology and oncology part. It's very simple. It should be very easy to go through, and it should have it's like 12 pages, but we've been using the same file for like 3 weeks right now, so you guys should be able to go through it and gain more and more information and emphasize this information in your mind. Because like in the next phases of the training, we have to make sure that all those information are actually in our mind, so we can build upon them in the next stages, in the next phases of the training. Thank you, guys. I'm glad we could make it today. I'm really thankful for you guys for the wonderful conversation we had about the next generation sequencing. Thank you, Nuran, for asking those questions, and thank you, Lauren. And you are always welcome if you have more and more questions that you get from your accounts to share with us. And I'd like to have a conversation over, like, to be presenting information, because this helps all of us. From now on, I think for the next weeks we're going to be only one group, because when we designed this training program, I was doing no other job than the training, and I was like working 24/7 on this. This is my full-time job. But now, since I'm going to be covering for Vanessa's territory in South Florida, so I'm going to be working a full-time sales rep as well. So I don't actually have a lot of time to prepare the material and go through it, and then do different groups in the training. So from this week, in the future episodes, is going to be only one group, and we should be. I'm not sure what time do you prefer, guys. Do you prefer to have it in the morning, Tuesday in the morning, or Wednesday afternoon? So go ahead and tell me what you think. Lori, you wanted to say something? Guys, wake up! The training is done. Now I'm asking you questions about which time is suitable for you.
Wake up.
Karim, I don't know what you mean by wake up. We're thinking about, actually, we already picked this time, I think, 5 o'clock, and for Aziz it's okay. So I would, and we kind of got used to it. So for me, this time is fine.
Yeah, fine with me too.
Okay.
Good with me too.
Okay.
Me too.
All right, sure.
Okay. Omar?
Omar,
Lori?
no pressure.
No, I don't like it. We got to change back to morning.
I'm not gonna be able to do 2 times anymore, because this is really exhausting for me, and I don't get the time to do this. I have to be on the road. I have a lot of appointments, and Vanessa's territory is really an important one, and it's a big one, very, very big one. So I don't think I'd be able to do 2 episodes anymore. This is gonna be very exhausting for me.
So you prefer this time then?
I mean, we have to choose only one. In the morning, I don't think Aziz is going to be able to join us, or Lauren, because this is going to be too early for him. So if you want to change it like from 5 to 5:30 or 4:30, this is the thing we can discuss.
Well, then you made up your mind for us already then, basically, right?
No, I'm just asking if you have any more suggestions. We are all open. There's no decision. And I'm actually the person who make decisions, Ahmed. So whatever we agree upon.
I know. I'm just kidding with you, man. It's okay.
Thank you. Really got me.
Well, what about 5:30? Does anyone agree with that, or keep it at 5?
Okay, so what do you think, guys?
5:30 means 6:30.
That's too late for y'all. Yeah.
Five, good.
So my kids should see me at some point.
I'm sorry, Katrina.
I said, if we start 5:30, we'll finish by 6:30, and I mean, I'd like to see the kids.
Yeah, that's too late.
I agree.
Okay, fine. I've been voted out. That's fine.
Okay.
No pressure, Omar.
I think it should be during the work, like part of the work day.
Hey, just a suggestion. I don't know. I didn't make it up.
Okay, no problem. Totally agree. So Lori said she's fine with this. Lori, have we heard from you?
Yeah, I'm fine. I was looking ahead at my schedule, but I'm fine.
Okay, thank you, Lori. So Aziz, have we heard from you?
He fell asleep.
I'm sure he's not mute. We should be listening to him. Aziz, maybe he fell asleep. I don't think Aziz has a problem with this time. So thank you, guys. So now we're gonna have the training Wednesday, 5 p.m. every week for all of us. I'm gonna be sending an email saying this because of we. So whom are we missing? We just missing Jean, right? Every other buddy is here with us. Jean and Ahmed.
Yeah.
Okay.
Jean has day off today. That's why she's busy.
Yeah. She sent me an email actually about this. She said she has to be with her daughter.
Yes.
Okay. Thank you, guys. Have a wonderful week.
Okay,
And
Karim. I have a question, Karim. So did you send us this PDF file already? We already got it?
Yep.
Okay, thank you.
You're welcome.
So, as I understand, we have to read it
Yes, please.
the next time, otherwise we will not understand the next part, right?
I mean, it's very important to read it.
Yeah.
You know, to get the information in your mind before we proceed for the next part.
Okay. Good. Thank you.
You're welcome. Lauren, you want to say something? Okay. Thank you, everybody. Have a good week and have a good weekend.
Thank you. Bye.
Okay.
Thanks, man. You're awesome.
You're welcome. Thank you very much. You're welcome. You're welcome, everybody. Bye bye. Take care.